Thank you, Zoe. Our third speaker is Dr. Nick Ward. Nick is doing a regional anaesthesia fellowship at Royal Perth Hospital, and tonight he will be speaking about the implications of video logging or vlogging in regional anaesthesia. Please welcome Nick.
Okay, good evening everyone. I'm Nick. I'm one of the regional fellows at Royal Perth, and I'm going to be presenting the slightly less technical topic of video logging or vlogs in regional anaesthesia. So firstly, I'm sure you'll be wondering what video logging is. There was a few people that thought it was going to be a handy cam in the corner of the regional bay at Royal Perth filming me doing ultrasound on patients, but it's basically just utilising the Sonosite LX video recording function to take sort of live screenshots, live action videos of my blocks as I carry them out. So the talks kind of inadvertently become a bit of a plug for the Sonosite LX, but it's what we've got access to at Royal Perth. So what I'm going to talk about, we'll talk about why we did it. I'll talk about what exactly we've been doing with the video logging, how we do it from sort of actually on the Sonosite itself, the video clip function. We'll be going through a few examples of the videos, talk about some of the potential uses, talk about some of the issues I've come across, and then finally just my overall take on video logging in general. So firstly, we'll go through sort of one of the first ones I did, so just a ducted canal, moment of truth as to whether this works. So we've basically been doing like a pre-scan, which we just do a scan up and down, have a look at the anatomy. You can set the clip on the Sonosite from 6 seconds right up to 60 seconds. Initially, my supervisor thought 6 seconds would be enough, but I don't think I'm quite quick enough for that. So it's eventually got to sort of 10 or 15 for me. The second one will be the needle tracking. So keeping in mind this is early in my term, so any critiquing can be done at the end if you like. But basically do a 10 to 15 second clip of the needle tracking getting into the place, hopefully the right place. And then doing the local anaesthetic injection, usually moving the needle around to make sure I'm free of the nerve, and then have a little recording of the local anaesthetic spread. And then finally would be a post scan to have a look up and down the area to see where the spread is. The ducted canal, that doesn't always work really well, so this one's just a little bit further injection that's been carried out. So why we did it? So when I first started the regional fellowship at Royal Perth, it was suggested that maybe it would be a good idea to use this function to record all my blocks to see I'd have this whole sort of storage and files of all the blocks I've carried out. And to be honest, initially I thought it was a terrible idea. I just wanted to get in, do my blocks, not worry about trying to record them. But once after the sort of first few weeks and a month and I got used to working in the block bay, it actually did seem to be something quite interesting to do. And I found it more and more useful as the term's gone on. So the idea was to have a video log of all my blocks, particularly to have like, I guess for me, a key example of all the blocks that I've done to refer back to and then use also as educational material as well. And the other point that really probably hasn't worked out that well, but just having sort of videos to have discussions on interesting anatomy or challenging blocks as well, which I think if you're doing a block on your own and you've got some difficult anatomy and you found it challenging or you've had to abort the block, taking a video of it then so you can take back and discuss it with some of the other regionalists. Okay, so what we've actually been doing. So at Royal Perth, we've got the block bay, get the patients into the block bay, consent them for the regional anaesthetic, and then make sure tell them about the videos, make sure they're happy with us doing a recording of the screen. And then, as I've kind of already explained, doing a pre-scan, doing the needle tracking scan, doing the local anaesthetic injection, and then doing a post-scan. And then eventually basically just transferring them onto a USB and then creating sort of files within my computer, and then labeling them so I've got them all stored. So how we do it, it's a bit more of a plug for Sonosite, and I assume not everyone has this Sonosite, but it was sort of tricky to figure out how to actually do it from the start. So this is the main home screen of Sonosite LX. So up the top, you basically go into the new patient category. And then we've been plugging in the MRN, particularly for when we've been looking for if we thought there might be some interesting anatomy. And then underneath, when you can, in the name, the last name, you can put what type of block you're doing, and then that will come up on the screen. And then when you export that as a file onto your computer on USB, it will come up with what block it was. And then if you click on institution, you can save it to Royal Perth, and then under departmental ID, I just put my initials. That actually sort of stays constant. So if anyone does any recording, it will always have that on. You've got to go in and change that. And so this is the video clip setting. So going back to the home screen, scrolling down, you can change that. So it changes from 60 up to 6 seconds up to 60 seconds. And you can change that depending on what block you're doing or how slick you are with a needle and an ultrasound. And then, yeah, basically down the bottom on top of the snowflake there, the freeze button is that little video camera. And as soon as you press that, it'll start the recording clip for you. The problem is obviously you can't really do it on your own. You need someone there doing it for you. So at Royal Perth, we've got a nurse assisting us in the regional bay, and often we've got a consultant and a registrar. But it's certainly a clunky element to the video logging, which I'll discuss further. And then basically you go into the menu, go into your patient list. You can see there, this is sort of, even just in the last week, sort of some of the videos I've taken from some of my blocks. And then you can go in, edit out any videos that are dodgy or don't show too much, and then have those sort of key 4 things, delete the ones you don't want, and then you can send them to your USB. So basically you just hit send to down the bottom and send it to your USB. So this bit is probably an example of how it's going to be useful for educational material. So earlier, just in the last week, I did a high sciatic block on a patient having an above knee amputation who had a failed sort of mid sciatic block. And so I had never done the block before, but we went and had a look at the anatomy, and this is a photo of we'll use this now, our skeleton over at Royal Perth. That yellow is supposed to be the probe, and then the blue is supposed to be the needle. So basically going sort of from the glutes down until you see the sciatic notch, and then basically needle tracking will go sort of just towards the bone there, with the idea that the local anaesthetic will spill into the sciatic notch. And the reason I think this would be useful is I'd never seen this block before, so I had to get my consultant to sort of show me the block, help with the scanning. The patient was awake. It just makes it a little bit more awkward, but if we had a database or some examples of these video blocks, it would have been much more smoother for me. So this is the pre-scan. So you can see when the bone forms together, that's going up into the iliac crest, and then that sort of broken bit there is the sciatic notch, and then we're sort of aiming for that left-sided bit of bone. You can see the piriformis is kind of overlying the area here, and then underneath it, there's not a lot of fascia, so we'll actually sort of just drip down into that sciatic notch. We use the Curvilinear Pro, so it's actually not too bad of needle pickup. Didn't quite get down to where I wanted in the 15 seconds. You can see me just coming down through here, basically hitting bone. And then just towards the end of the clip, you'll see my first little bit of local anaesthetic injection. And you can see the piriformis lift up. Now my needle's actually moved over a little bit closer, just so a little bit more of that spread's going to get actually right down in there. And then this is the post scan. So you can see there's a lot of local anaesthetic all over that sort of sciatic notch. And the block actually worked really well. Patient had a really dense block and was able to have it done under just a little bit of sedation and surgical blockade. So potential uses of vlogs. So the one thing I didn't really consider before it was reviewing my own technique. So particularly when you start to get more independent in your practice as a fellow and you do a block without your consultant there, your consultant might be curious as to what you did and how it went, and you've got a video there to show them. Also, if you found it a little bit challenging or you weren't convinced in your local anaesthetic spread, or even if you thought it was really good and the block didn't work very well, you've got this sort of resource to go back and sort of critique your own practice and have someone else sort of help critique you as well. And I found that quite useful, particularly as the term's gone on. I think having a video of every one of your blocks when you finish your fellowship is very useful, both just for yourself when you haven't done a block for a long time, can go back and refer to it, and then also just for educational stuff, ongoing talks, just having these videos your own where you don't need to go to YouTube or WASORA. You've got sort of blocks that you've done and you're familiar with. For the fellowships, as I kind of just already touched on, having access to preview of blocks, I think it would be great for every department to have some key sort of videos of their own blocks that they commonly do, that fellows that haven't done them before can have a preview to them prior to carrying them out. And then the other one, which we haven't managed to get a whole lot of during the term so far, but is that unusual anatomy and challenging blocks to sort of generate discussion. So potential issues. So some of the minor issues. So some of the, when you put the name on the blocks, sometimes the video file doesn't save with the actual type of block it has on it. So you have to go in and edit it straight away, which is, if you've got a whole bunch that you've done at once, it can be a bit annoying. The other thing is it takes quite a long time to do this, so it's not as quickly putting your ultrasound probe on, getting a quick block in, and getting the patient in to theatre. It takes a lot more time. You need someone there. You're just kind of hit and go, doing your pre-scans. So it's probably not something you do on every block, but it's certainly when you've got a bit more time, and the Royal Perth regional base certainly lends itself to that. The transfer to USB actually takes quite a bit of time, and I think if you're sharing that sonosite between multiple theatres and multiple different areas, you might lose your USB, because sometimes it can take half an hour to an hour, and then you've got to go and transfer onto a computer as well. And so it's quite clunky needing to have that person press record, but the ASM last week, Sonosite were there showing their new voice activation mode for the Sonosite LX, which is actually pretty neat. You basically just say voice activation and then record clip, and it will record that video clip for you. So that would certainly alleviate some of those sort of the clunkiness I've had with the video logging. So maybe solved. We'll watch this space. Potential controversy of it, I guess the kind of medico-legal implications of us having sort of recorded videos of the blocks being carried out, particularly if something was to go wrong with the blocks or neuropraxia was to occur. On one hand, if the block was sort of carried out well within the bell curve, it could be really reassuring that nothing was done wrong. But then if it was a challenging block with a bad outcome, then we've got this recording. So I think probably my take on that would be that we wouldn't be doing with everyone. It wouldn't be like a database storage of every block carried out of the hospital, and we'd sort of be tailoring it more to educational material. Cool, so my overall take on vlogs. So the positives, so I've kind of said this a few times now, but fellows having a video of all their own blocks is, I think, very useful, and I'll be really glad at the end of my term that I'm going to have that, both for my own reference and for future educational opportunities. Very useful for reviewing your own technique after blocks. And I'm sure there's plenty of people, consultants that have been doing it for a long time, that would come across blocks that were challenging or they found challenging for various reasons and would like someone else to have a look over it. And it's also just a great education resource for the departments. So limitations, the time-consuming nature of it is one limitation. And I think early on in your fellowship, it's not a great idea. You're just trying to get your hand on the ultrasound and get used to the flow of the regional service. And I think doing it on every block would really start to delay efficiency. So that is certainly one sort of limitations. I think governance over the videos would need to be really established before we're doing this, rather than just, obviously I've just done this as a little project. But I think if it, like a regional department was going to do it, there'd need to be someone that had sort of governance over those videos. And as I've touched on, that sort of medico-legal implications of having sort of video recordings of our blocks, I think at this stage, rather than it being a full database of every block, using it as educational material. That brings me to the end. I think questions and comments are in a little bit. So thank you.